In this episode of Cutting Edge Health, today we're talking about depression and migraine and why they go together like Bonnie and Clyde. If we haven't met, I'm Dr. Orlando Landrum. I'm a physician that helps patients understand the aspect of how to be able to know your options for dealing with pain, whether it's physical or whether it's mental, and how to be able to help improve both healing the brain and the body and getting back to leading the life that you deserve. Today, we're talking about migraine and depression, which affects a number of people where they have the aspect of both problems, where they have migraines and they have depressions and depression symptoms. And they know that when you treat one, sometimes you can improve the other. What many people will say is, oh, a migraine is causing this depression because functionality and life choices and things along those lines are altered. But actually, it's more complicated than that. So when we kind of get into it, one of the things that we can see is that both of the two problems have a similar genetic profile. They affect the brain in similar ways. They have psychological factors that are similar, and they have stressors, which both cause them to have issues. When we look at this in depth and detail and we kind of assess this even further, we can see that they're not unique. There's some other things that actually also are similar to migraine in terms of areas that have autoimmune disease, things like asthma, insomnia, irritable bowel, diabetes, cardiovascular diseases, and how they are actually connected. But the interesting portion about migraine and depression is that they're so similar in these other mentioned areas that were stated, not just genetically, but also the mechanisms from our brain and stressors and psychological factors that seem to influence them the most. So what we see is that depression and migraine, they both, from what we can be able to derive, have an issue with the intrinsic brain activity that's present in the left medial prefrontal cortex. So that's the area that sits in and around this area and region. One of the ways that we treat depression, as those of you who follow our channel know, is by using things like TMS, transcranial magnetic stimulation, which is targeted to that region and is able to improve the symptoms and actually lives of many patients. But what we don't pretty much know is that migraine sometimes has an orientation in that same area. And we see these issues with connectivity that's present where it connects into different parts of the midbrain, like the thalamus and portions of the insula, and it can result in either of these two areas by starting in that region. For those who have migraine and have been following it pretty aggressively, particularly over the last 5 to 7 years or so, we know that the CGRP treatments have been pretty prominent. And what we can see is that that's not just the case for migraines alone, but that there's some connectivity of how this affects depression. And we can see, as mentioned before, this headache to thalamus to this aspect of the CGRP that's in place from this cartoon that's present. And we know that it can affect the serotonergic system and how it affects the peripheral neurons. And all of these are interconnected. So go figure. When we think about historically it just being, oh, well, you have a migraine, so that's going to then result in you being depressed. Actually, no, there's molecular pathways and there's genetic pathways that really support how the two are intertwined. So what we see when we get into the full depth of it is that there's 180 genetic variants that are present that look at how it impacts both the aspect of the vascular systems, the arteries and the veins, and the nerve systems that are present. And these all actually have various different receptors that are present in different parts of the nervous system. And these various different receptors have genetic elements and expressions that are in place. So when we take a look at that in depth and detail, we can see that these changes that are present that cause us to be more susceptible to both problems result in issues. So as alluded to, and I won't go into the depth and detail, but you guys can kind of see it here. We have presynaptic terminals, we have postsynaptic terminals, we have the distribution and uptake of glutamate, which is obviously key. We have these assistant neuronal cells like astrocytes, and all of these have inputs of either calcium or sodium potassium mix. And if they're not functioning correctly, it can throw things off. And what we're able to kind of be able to deduce is that this is not just at one site, but it's widespread throughout the aspect of the brain. So what we're able to be able to deduce is that it's able to impact this connectivity. And there's a number of things, whether it's the hypothalamus, the thalamus, whether it's glutamate, GABA, whether it's serotonin itself or sexual hormones that are utilized. These elements have a key connection to how both the expression of depression and migraine is present. So what we can see here is in major depressive disorders, the levels of CGRP are associated with severity, and we certainly know that's the case for headache. And depressive symptoms in patients with migraines is even more exacerbated. And we can see these A delta fibers, which are fibers that are consistent with pain, and CGRP that are in place, and how these changes are affected from a genetic standpoint. For those of you who want more depth and detail, we're going to run through a few different tables that can kind of show you that. But what we see is when we take a look, we can see these different receptors, which you can see out to the left that we kind of highlighted pretty quickly before. And we can be able to identify what are the genes that are present, the number of cases that are actually represented in the literature, and what are the specific areas within that receptor that's affected. So that's what these show. Then when we go into the various different actual receptors that are involved with both depression and migraine, what we can just be able to see is like dopamine. It has an antidepressant that affects dopamine channels, but those same things can be able to affect how the synaptic transmission and how migraine is expressed as well. What we can be able to determine is that there's other receptors like the MTHFR-C677T that's present with different changes within components of our blood, like homocysteine, folic acid, and vitamin B, and how these can have impacts on how migraine happens and how the central nervous system deals with depression. So serotonin is another element that looks at the effectiveness of neuronal transmission. What we can see is that different selective serotonin reuptake inhibitors, which are used for depression, also have impact on migraine symptoms as well. In addition, what we've also kind of recently seen is the utilization of the endocannabinoid system and how that endocannabinoid system is affecting the aspect of the nervous system as a whole, and how it can impact migraines as well as the trigeminal vascular system as a whole. So when we go into further like pictures, we can see these representations of the serotonergic system, how it's impactful for the areas of migraine is what we well know, but it's also impactful for the components of depression. And then going on, we can see it further with how the brain relates to different parts of the body, whether it's the hypothalamus, the trigeminal, whether there's a vasodilatation that's in place. And this is a representation of prostaglandins and prostacyclins and the hormones of estrogen and progesterone, which when they are different and when they are not quite optimized, we can see that there's changes that affect serotonin, and that serotonin on the one hand can affect the aspect of depression, and on the other hand, things like norepinephrine and areas of GABA can also affect these same areas. So it's this multifaceted effect that impacts migraine and depression repetitively. So again, looking at the different hormones of estrogen, and we can see changes that are present that result in either the presentation of serotonin or noradrenaline. And then progesterone has a similar type thing where you can see it can be able to, with the utilization and production of MAO, have serotonin degradation with an improvement in depression and pain. And we can see this other element of GABA, which activates the trigeminal nucleus, and it can be preventative in migraine. So at the end of the day, when we really kind of get down to it, what we can really be able to identify is the following, is that the genetics of migraine has been clearly identified to have this crossover with these molecular abnormalities, meaning these other ways that it actually works, that it impacts both depression and it affects migraine. And what we can kind of see in this like red box is that the shared genetic background between the headache and psychological traits which make us vulnerable to depression is highly correlated. And accordingly, when we take a look at this, we can be able to know that these things can then be utilized to our benefit to say, can we be able to treat both of these with a succinct treatment? It doesn't necessarily always have to be medicinally oriented, but we use the mechanisms that medications can be able to deploy in order to be able to get improvement, to be able to provide relief and give us some sustainability. For those of you who are attending for the first time and you found this video helpful, please hit the like button and give us a subscription if you're interested in learning about more types of topics that sometimes are unique, but actually make a huge difference in people understanding their options for knowing how to punch pain in the face and getting back to leading the life they deserve. Thank you so much for joining. And if you have questions or comments, please leave them below. Have a great day.